Hi, this is LKruse, and I'm doing my presentation on the role of an echoic repertoire during error feedback. So there was a great quote in a Mueller, Pakovic, and Maynard paper that says, "Errorless learning is a bit of a misnomer. It is not always totally errorless, but far more often than not, rather error-reducing." So we all know that errorless learning is recommended, especially with individuals with developmental disabilities, but it's not always possible. So Rogers and Iwata looked at when errors are made, providing basically no consequence whatsoever. So just doing differential reinforcement. So if they got it correct, they got something. If they got it wrong, nothing happened. Versus doing two different types of consequences. So one was where they were prompted and then able to access reinforcement. And then the other was where they were given a number of other demand tasks. And so they were given the correct answer, then giving other tasks. And so it was considered an avoidance condition. And what they showed was not, one of those conditions was not preferred or not more effective across the board, but rather it varied a little bit. However, having a consequence for that error was better than the control condition where there was no consequence for the error. So then Carroll, Joachim, St. Peters, and Robinson later on did a study where they compared 4 different error correction procedures between autism and ADHD in children with both conditions and looked at what was going to be most effective. And so they measured being effective by how many trials it took to master. So they had their 4 different conditions. They had repeat and represent and repeat, repeat until independent, and went through, and those were, the repeat till independent really was the one that showed that it was the most effective, so the fewest number of trials. However, if you think about that, representing over and over until the child is independent, fading your prompts, although that time from the initial error until the correct independent may take a very long time. So there's a very high effort requirement for both the therapist and the participant in that study. So when we talk about effective error correction procedures, what really do we mean, and what about efficiency? How does that play into things? So a lot of the studies just measure total trials to mastery, which really theoretically is potentially the least amount of effort from the learner. Not always, but potentially. So fewest trials, fewest demands potentially being placed. Is it the total time until they hit mastery? So what if one error correction method is a lot faster to implement than another? So in the prior study they had where they just represented once and prompted the correct answer versus representing until independence was reached. So obviously those would take different amounts of time. And then what about ease of implementation? There's a lot of studies that look at treatment integrity within discrete trial training, and that when treatment integrity decreases, it impacts skill acquisition. So the higher the treatment integrity, the faster skill acquisition, and you have lower rates of maladaptive behaviors too. So ideally, of course, you want the highest treatment integrity possible. So what are some ways that research has shown we can potentially increase the efficiency of an error correction procedure? So Turan, Moros, and Croteau, they did time 2 different error correction methods. So one was just a delay, where they presented the correct answer and paused, but they did require an echoic from that. And then in the other, they presented it, made them do a couple distractors, and then represented it and did require the echoic as well with the prompt. So, or the imitative skill with the prompt. So both of those did still require that active learner, and they showed that both showed the potential to be effective. Both led to learning and skill acquisition, but that just a simple delay without adding in those distractor trials was twice as fast. So it only took 9 seconds instead of 18 seconds. Then Warsdale, Iwata, Dozier, Johnson, and Thompson did a really interesting study where it was 3 different experiments, but in the final experiment, they tested where they first they gave the participant erred, They gave them the correct answer, and then they had them practice repeating imitating the correct answer. And then they ran a condition where they had them practice. They would have them give the correct answer, imitate that once, and then they would have them practice a completely different, irrelevant word. What was so fascinating about it was, although they were definitely faster in that practice condition of the actual target word, they still acquired the other target when an irrelevant word was the word that they had to practice with. So they were hypothesizing that perhaps merely just having the correct answer presented to them may have been sufficient for the participants in their study to still learn that tact. So then another study with Smith, Merzick, Wheat, and Hughes, a number of different error correction conditions tested, but none of these conditions required active learner responding. So in none of them did they actually prompt the echoic or prompt the imitative skill. And again, what they saw was there was just a lack of a consistent procedure that always came out as being the most effective or most efficient. So thinking about what those studies did, that leads us to this model prompt, this model error correction is what I'm calling it. So McGann and Lerman, they had the model error correction prompt in their study as one of the different error corrections. And it actually put in their discussion that they were, quote, somewhat surprised that the model correction prompt was not only very efficient, easy to implement, but very effective, just as effective, if not even more effective for some participants than the more invasive error correction prompts. So they were really trying to look at the invasive error correction prompts versus the less invasive and coming up with a less invasive, which I think you could also consider being an efficient error correction procedure. So Townley, Cochran, Leaf, Taubbaum, and McEwen also found that just a model prompt was effective, but they didn't have any good conclusions as to why. They just noted that even when the correct response was just modeled, that participants were able to acquire that skill. So then the Kodak et al. Study in 2016 had that condition as well, along with a couple other conditions, but what they noticed was for 4 out of the 5 participants, it was extremely effective. So for 3 of those 5, just the model was more effective than any of the other error correction procedures. And for the 4th participant, it was the second most effective. However, for the 5th participant, they did not acquire those targets at all. So it was completely non-effective. So what was the difference between these two groups of who it was effective for and who it wasn't? And what they noticed was those that it was effective for echoed that model 79% of the time on average, whereas the participant who did not learn the target in that condition, they only echoed 7% of the time across all the trial blocks. So, is it this echoic? So, an echoic, Skinner defined, and I will fix that slide real quick. Skinner defined as a response to an auditory stimulus that has point-to-point formal correspondence with the stimulus. So I'm calling there's the unprompted when hearing an instructor say apple, the child just naturally says apple, and then prompted when the instructor is saying say apple, the learner repeats the apple or say apple. We'll track both. And Kodak and Clemens also did a study that showed they looked at man training and tact training, and really when they looked through them and they weren't making progress on certain skills when they ran just the man trained tact training, but they had a low echoic. When they added in echoic training, it actually improved the manding and tacting training as well. So perhaps there's something about this echoic as like a behavioral cusp that allows additional learning to occur more naturally. So the research question, the proposed study seeks to validate the use of this model error correction procedure for individuals that have various echoic repertoires, and then to measure the impact of prompting an echoic as a remedial treatment. And this is for 2 reasons. The first is the procedure is significantly more efficient than those more invasive procedures. So it's faster to implement. So you can potentially get a higher rate of skill acquisition if you're measuring over time. So the amount of time it takes for, if I show a picture that of a dog and the child says bear, I just say dog and move on. That's a lot faster than if the child labels it bear and I say dog, now clap your hands, touch your nose. What is it? This is dog, dog, and try to fade my prompts out. So it's very easy to implement. It's very quick to implement. And if it is effective, then a high rate of skill acquisition can potentially be achieved. And then secondly, since it is so simple, it might potentially be implemented with a higher treatment fidelity. And we know that that higher treatment fidelity has led to better skill acquisition and maintenance. So my specific proposed study is going to use 2 to 6-year-olds diagnosed with autism. They have to have at least level 1 skills in the VB map, specifically in tacting and listener responding. They do need to have been in an ABA program for at least 3 months because my goal is to test a skill acquisition procedure, so they need to be familiar with sitting at a table, cards being presented, the basic kind of instructional control that goes along with that. The exclusion criteria are going to be severe or self-injurious behavior, since I'm really focusing this on skill acquisition, not on behavior reduction. And then any individuals that use ASL or AAC devices as a primary mode of communication will not be able to participate in this study. I think that could be a great potential expansion, but not at this time. The setting will be a private ABA clinic, and there'll be a computer that'll record all the sessions. 3 by 3 inch flashcards will be made of somewhat more uncommon pictures for the kids. So there'll be a bank of 40, and then they'll be probed. 20 of them will be assigned per participant, and then those 20 will be randomly assigned to either the control condition or the model error condition. So I did find this great site that's randomlists.com that'll just, you tell them how many random pictures you want and what category, and it comes up with a bunch. So that's just a quick example of some of the random pictures that 2 to 6-year-olds, they may know some, but they may not know all of them. The experimental design is going to be an alternating treatment design with baseline, and then there'll be a remedial condition as well if mastery hasn't been met. So this is just an example, but you've got your baseline over there on the left before the dotted lines. Our baseline will have to be kind of consistently under that 30%, and that a stable baseline for at least 3 data points for each condition. And then you have the alternating treatment, the treatment phase, where you'll have the 2 different ones alternating. And then the follow-up remedial phase, if it does not meet the mastery, which is going to be 100% for 2 consecutive sessions, where it'll be prompted to engage in the echoic. The control will stay as a control throughout the entire thing, and then there'll be a maintenance probe as well. We'll go over this again when I review the full procedures. The dependent variables and response measurements are going to be, there's a couple of them. So percentage of correct responses, so each trial block will have the correct responses out of 10 trials times 100 to get that percentage. The correct responses will be on the paper listed as the actual tact that needs to be understood by the instructor. The instructor and the IOA data takers obviously will likely not be familiar with that individual child, so therefore the tact does need to be understood by that person. Skill acquisition rate will be measured in 2 ways. It'll be measured as total trial blocks to mastery, as well as a total duration of time it took to get to mastery. And then the presence or absence of the echoic will also be measured. So there is no functional echoic opportunities during the control or baseline or the maintenance probes, but during the model error correction conditions, there is. So if they err or they do not respond, so it could be that the error could be that they don't respond within 5 seconds, the instructor will say the name of the target pointing at the card, and then if the child echoes it, it'll be recorded as a positive, as a plus for the echoic. They do not re-record as a minus. In the remedial condition, the instructor is going to say, label it, and then say, so dog, say dog. And then data will be collected on the child saying dog or say dog. So both ones, just to see if there's any slight difference there. Kind of that over generalized echoic or just the actual echoic with that prompt. IOA data will be collected for at least 33% of all sessions. It must remain about 80% or higher. It'll be evenly distributed and kind of randomly assigned to the different conditions. And then here's kind of the overall procedure. So phase 1 is that screening. 40 pictures are probed. They need to have at least 20 of them that were unknown on that first screening. The baseline will be a cold probe of all of the tacks. They'll be split into 10 and 10. And then we'll need to have 3 consistent data points. It's actually below 30 or 40%. So just that they don't know most of them. If 10 blocks go and they're still really unstable, then we'll stop the baseline at that point and move on to the treatment. The treatment condition will have the TAC training with the 2 different conditions, and then 2 blocks at 100% or 50 total blocks without mastery. If mastery is not met, then the remedial training will occur, which will include the prompted echoic and then have the same mastery criteria, and then maintenance will be a cold probe of the 10 tacks. The baseline, there'll be 20 total words, so we have 2 different conditions. The control condition is going to be green, the treatment condition is yellow. Presentation of the cards and conditions will be randomized. And then the baseline procedures, so in order to have that observing response, at least at the start of each block, there's not a specific observing response required between every trial because these are going to be children who have been in ABA, so they should be used to that format. But there will be, for multiple reasons, there will be an observing response just to make sure they're attending as well as to gain their assent. So before the study starts, obviously the parents will give consent for their child to participate in it, but we are going to attempt to collect assent from the child as well. And so assent looks like 2 things in this study. The instructor will say, if you are ready, touch green or touch yellow in the error correction condition. This is also something that is traditionally done in alternating treatment design, where each condition is distinguished by some sort of stimuli. So these 2 different color cards are providing that cue. And so the assent will be first that if you're ready, touch the colored card, as well as there'll be a behavioral component to the assent. So if the child engages in more than 2 aggressive behaviors that last more than a minute or more than 1 self-injurious attempt, that we will consider that the child is refusing or withdrawing their assent for the day, and so we'll stop the session for that day. And then we would talk with the parents, and it would be their decision if they wanted to continue. So if the child does that throughout the entire study for more than 5 sessions, we have to stop. We will then automatically withdraw them from the study. There will also be, prior to the baseline, a preference assessment done. That'll be a multiple stimulus without replacement. A parent interview will happen first to get kind of about 10 items that the child may potentially find to be of high preference, and then a multiple stimulus without replacement will be done. When they get their reinforcement breaks, they will be given a paired choice between a couple of the top choices from their multiple stimulus without replacement. So the baseline procedure, if you're ready, touch green, hold the picture. What is it? No feedback's given. Data's collected. After they do 10, they get a 2-minute reinforcement break. We need those 3 stable data points. In the treatment phase, for all the conditions, it's going to be that hold up the card. What is it? Correct response gets animated verbal praise and a token. 5 tokens will get them a 2-minute reinforcement break. And then at the start of the control block, it's if you're ready, touch green. At the start of a model error correction block, it's if you're ready, touch yellow. So for incorrect responses in the control conditions, same as baseline, there's no feedback given. It'll just go on to the next trial, and if there's no response after 5 seconds, or if there's an incorrect response, then after 3 seconds, it'll go back to the next trial. For the model error correction, the correct answer is modeled, just modeled, but no active learner responding is required. So they say bear with the picture of a dog, say dog, point to it, move on to the next trial. It ends again after 50 blocks or 2 consecutive blocks at 100% for one of the conditions. The remedial phase will be basically run the exact same as the treatment phase, except it'll be prompted. So it'll label dog, and then we'll say dog. So then we'll collect data still in that percentage correct and that presence of the echoic. Same termination conditions. Then after all the conditions or the phases are completed, we will go into the maintenance phase. So we'll be 2 weeks after, and all 20 words again will be probed for percentage correct to see if they maintained them or ever acquired them, if they match kind of what it was at the end of the study. There'll be a debrief with the parents, so we'll review the overall data as well as the overall study, and then any Q&A that the parent has, and then there'll be a social validity questionnaire that'll talk about, it'll be a Likert scale 1 to 5, and on how the parent felt about the goals of the study overall. How did they feel about the procedures that were done? How did they feel about their child's outcome? And is it something that they would want to be trained or train others who work with their child on? So this Skinner quote is one of my favorite. The failure is not always a mistake. It may simply be the best one can do in the circumstances. The real mistake is to stop trying. And so I think something with error correction, we're often scared at times to let the child make the mistake, but we may have a really easy and efficient way to kind of remedy that. So if potentially, if what this study shows is that when that echoic does occur, it makes the model error correction work and be effective, then that lets us know that that's a really good prerequisite skill, and we can say once a child has a strong enough echoic repertoire, we don't need these more intensive and invasive and time-consuming error correction models. I also think that this model error correction procedure is one that can much more easily translate into a natural environment and into a gen ed setting. Which is the ultimate goal. So we have these great ways to fade our prompts. We have great ways to fade schedules reinforcement. We don't really have a lot of suggestions on how to fade your error correction. And so potentially this may be one. So it's maybe sufficient. It's very effective. It could be very effective for certain individuals. It's very efficient, and it could lead to very high treatment integrity, which is always what we want. And if they don't fully have that strong echoic repertoire, it really does speak to the power of that echoic training, and that really making sure that we do sufficient echoic training that may really help these individuals with their skill acquisition rate in general. So that is the summary of my study. Here are the selected references, and thank you very much.